The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. This is Connie Rao. I am the Executive Director of the American Academy of Home Care Physicians, and it's my pleasure to welcome you to a webinar called Home Health Medical Direction Online Training, which is a program of ours that was developed with support from the Alliance for Home Health Quality and Innovation. Dr. Edward Ratner, who is the course director, will be our speaker today, and I'd like to turn it over to Ed at this point. Ed?
Thank you very much. And I can't see any of you, but let me introduce myself, and then I think since we just have a modest number of people online, we can kind of go around and I can take names just so I have a sense of what geography of who is on the call. Very briefly, my background, I'm an internist and geriatrician, trained in medicine in Chicago, been back in Minnesota for about 25 years, and have focused in home care medicine for about the last 15 or 20 years. Had done house calls as early as my residency, but became a home health medical director for one of the large healthcare systems during kind of my first job after geriatric fellowships, and have pursued that as a major portion of each of my jobs over many years, as well as being faculty at the University of Minnesota. And I currently am a clinical staff in home care medicine for the Veterans Administration, and working part of a spinal cord injury program where I organize home care services and programs and make house calls for paralyzed veterans. So let me kind of quick go around and see who's on the phone. Can people speak, or are they all on mute?
No, they're all on mute.
Oh, okay. Well, then you're not going to be able to tell me who you are. So, but I'll assume that we have some distribution of people across the country. And I think we have about 10 or 15 people on the line. So why don't we go on to the first slide, next slide. I'm just going to have one of the staff people change the slides for me. Okay, first issue is in terms of this talk and the training for home health medical directors that I wanted to share with all of you is why should home health agencies have and train their medical directors? And this is essentially the same list as the learning objectives for the training course. One of the reasons to have a medical director is to promote the increased use of skilled home care services. And I think that most agencies are actually seeking to serve more people than they are currently, and recognize that it is a type of service that is actually underutilized, although there may be government officials that say that there's some concerns about overutilization. Far more people are eligible and would be appropriate for home care services than actually receiving such services. And medical directors, if chosen correctly, can be both a source of referrals in their practices and their colleagues' practices, as well as advocates for referral to skilled home care services and within a hospital medical staff or within a specialty society. Second reason to have and train medical directors is to improve the quality of home health care. The tradition of home health care being primarily a nursing with a bit of add-on therapy, or primarily therapy with a bit of add-on nursing, does not recognize the increasing complexity and needs of patients receiving skilled home care services. And as in the nursing home or hospice where medical directors are required, home health agencies can use the expertise of physicians if they're recruited and trained properly to enhance the ability of the nurses and therapists and other staff to provide excellent care. Third reason to have and train a medical director is to assist in stewardship of the home health agency resources, and whether you're representing agencies that are primarily nonprofit or for-profit, whether they're affiliated with hospitals or health systems or standalone, the management of the revenue that comes in, particularly under prospective payment versus the expenses for the care, is an important aspect of every senior managers and administrators and director nurses role. And medical directors can assist in this. Good example that we'll talk about maybe a little later is in making decisions around choice of wound care products and care plans that meet the financial incentives built into prospective payment. And the fourth reason is, particularly if you're going to have them, to train them, is that there are a variety of federal regulations that address the role of the home health agency medical director and the contract between the agency and the medical director that one can run afoul of on either side of that relationship. And just as with other compliance training for other staff, the specifics of the issues of compliance with federal regulations, Stark, for example, and anti-kickback rules are important for home health medical directors. Next slide. I want to touch on the range of activities of home health medical directors in home care. And that you're probably mostly aware that home health agencies, even if Medicare certified, are not required to have a medical director, unlike hospices or nursing homes. And at minimum, the conditions of participation require an annual professional advisory committee, and a physician needs to be on that. So that would be the bare minimum, is to have a physician show up annually at such a meeting. Many agencies have those more frequently because they find some value in that, and so quarterly PAC meetings would be common. And some medical directors are, and then may not even be called a medical director, but technically if you're going to pay them, you need a contract, and the terms have to meet all the regulations if you're going to pay them to come to such meetings. That attendance at those meetings would be a type of relationship. Pretty minimal, doesn't accomplish much, if any, of the goals that we talked about in the last slide. A maybe more typical kind of meaningful relationship would be expecting the medical director to show up on site for meetings of a quality committee or leadership committee, to perform chart reviews, to provide phone consultations if things come up, to make the prescription for the tuberculin that is needed for pre-employment or annual screening for TB, and some of those kinds of activities that would require a few hours a month. Larger or more sophisticated agencies may have clinical team meetings comparable to hospice interdisciplinary team meetings for newly admitted or difficult patients, and include a medical director in that activity. And the agency, which was part of a national corporation, long-term care corporation, that had about 100 home care agency sites, that was kind of the standard for medical directors to participate in their weekly IDT meetings. Some agencies are affiliated with a hospice or a nursing home, and the medical director in those organizations or facilities might, as part of their job, also serve as a home health medical director to deal with issues and questions as we described above. And then finally, some of the kind of more, I'd say, advanced agencies have contracted with or actually employ medical directors for a number of hours per week, a day a week, or even full-time in some larger agencies. And the value of that is the same as the value as a variety of other roles in the agency to achieve better care, promote the agency, and to improve the financial sustainability of the agency. Next slide. In recognition of the growing importance of this role, and I think as we move toward accountable care organizations and more creative relationships between home care and the rest of the health system, there is a recognition of a need for additional training for home health medical directors. The American Academy of Home Care Physicians has been active in training of medical directors for, I'd say 20 years. And back in the olden days, in the 1990s and earlier, when we had cost-based reimbursement under Medicare, the Academy of Home Care Physicians offered several day-long on-site training for home health medical directors, and we would have over 100 attendees at such meetings several times a year. And from that, we retained kind of the expertise and the materials and the focus on the needs of physicians who spend some or a considerable amount of time in a home health medical direction. Rather than thinking we can recruit and agencies will compensate and pay for travel for such intensive training, we've reduced this down to about 4 hours of training and broken into smaller segments based on how physicians can tolerate online learning. Maybe everybody is best trained in smaller increments rather than the traditional 1 hour live in-service. And so we have 8 modules that are roughly 30 minutes in length. Unlike some types of training where you might have a pre-test and then you watch a bunch of slides or hear narration or watch a video and have some post-test, we have seen this as a competency-based training where you as leaders of associations of home care agencies recognize that it's not getting 70% right isn't good enough, that if we want people to know things, we want them to know all of those things. And so we've embedded the questions into the module and require correct answers before the person moves on, which means that they can correct themselves and work toward getting the right answer, but they can't actually complete the activity until they can demonstrate that they can pick the right answer or answers. We also have evaluation at the end of each module to see, get feedback and improve this over time. The modules are completed in order because they build on each other, so they're not each standalone. And the 4 hours of AMA continuing medical education credit, as well as family medicine and certified medical director hours are offered for completion of this entire course. This is kind of a legitimate course using the best practice online education methods. And it was created in collaboration with a nationally recognized firm that does online training for physicians and other health professionals. So it comes out looking professional. And we'll look at a few of the slides so you can see how it looks. The next slide. We have the 8 modules, and I wanted to run through those titles so you can see the range of things. And you may kind of say, oh, geez, as a association leader, I'm not fully familiar with all of these things, or I could use an update, or I'd be interested in seeing what physicians are being trained in these areas. So I would encourage all of you who are participating in this call to consider enrolling in this course. I'll turn it back to our staff of the Academy to see how we can make that efficient and easy for you. But the initial is just a background of home care medical direction, and to a great extent it's about what the home care industry looks like and the breadth of home health services provided by Medicare certified agencies, as well as the variety of other things that are offered. And I'll go through the slide titles for that first module. Have a module on quality and accreditation and the whole OASIS system, as well as the variety of ways agencies become certified, and sometimes directly or through accreditation agencies. Have a module on eligibility in terms of homebound status and what are skilled services. And related to that, obviously, is what services and supplies are included in the Medicare home health benefits, and going through each of the types of services so that certainly a medical director, but not only themselves, but they need to educate other physicians on the wide range of things that can be provided and are included in the health benefit. But the flip side is understanding some of the limitations and the financial incentives related to some of those. And we get into that in more detail in Module 5, which explains the reimbursement system under the Medicare Medicare prospective payment system, where the first 4 visits are paid on fee for visit if there are 4 or fewer, but for longer, more intensive home health episodes of care, the prospective, complicated prospective reimbursement formulas kick in. And I don't go into great detail on the actual formula because I think that's beyond what physicians or medical directors need to understand. But to appreciate the range of reimbursements that are offered, at the low end in the less than 2,000, at the high end, 5, 6, 7,000 for the most complex case. And then finally, some of the innovations and incentives that have been created or tested in home care. Go to the next slide. The sixth module is both for medical directors and would be very useful for all attending physicians, and about their roles in home skilled or Medicare certified home health. And it's the referral process, the completion of the plans of care, certification and recertification of the plans of care, or 485s. And we have samples in the module so they can, if they can't say, well, I don't know what form are you talking about, so that they can see what they look like. I have some detail on care plan oversight, which is an important activity for the attending physician and need to be encouraged by medical directors. Physicians need to pay more attention to the episodes of care throughout the episode, returning phone calls, completing paperwork in a timely manner. And finally, the face-to-face issue rules and what role the attending physicians have and what role the medical directors can play in compliance with the face-to-face visit rules. And if any of you aren't fully familiar with all of these aspects of the home health care Medicare operations and rules, I'd encourage you to walk through this brief module. So the most clinically focused module that I think in my experience over many years as a home care medical director, ranging from, for some agencies it's been, an hour to a year to half-time for many years with a large agency, is wound care. And the medical director doesn't have to become a wound ostomy nurse and be expert, but to appreciate the range of types of wound care that are available, the types of dressings that agencies might be asked to use, and particularly I have a number of slides in this module about negative pressure wound therapy or wound vac therapy, which has a very complicated relationship to home health agencies and reimbursement issues and eligibility. And medical directors should be familiar, if not know it really well, because the negative pressure wound therapy is growing and becoming a standard part of what home health agencies are expected to do. And finally, the last module focuses on some of the higher tech care, infusion therapy, and I served as a national medical director for an agency for home infusion for a number of years. And that's a specialized aspect of care, and not every home health agency does that kind of work, but every agency might encounter a patient who requires it, and then the collaboration of that agency and the other agency or agencies that are providing infusion therapy for their patients is important, as well as how to work with the pharmacists who are the key players in home infusion therapy. Other complex care in home health care is addressed in this issue, including ventilator care at home and some other interdisciplinary aspects. Next slide. So this is an example of a screenshot of an introductory page from the introductory module. And as you can see on the left, we have about 15 slides for each of the 30-minute modules. And we try not to overload with changing the page, but I'll just run through so you can see in this introductory module. We start out with a case study that I'll describe, go into the scope of home care, scope of Medicare home care, some of the demographics and types of services that are being provided in home care, and that comes from the actual reports from and a Medicare agency that describes their agency, and then the national norms. And so we have those information in this module. A little about OASIS reports and what they look like, the roles for home health care, another case study, regulations, the medical director contracting, the roles for medical director, team members and the wide range of team members that are on some larger and more comprehensive agencies that medical directors typically are recruited to serve. Some of the organizational culture, and that's an important issue in home care, and we'll look at that slide. And an important issue for training medical directors, how to not think of themselves as primary care physicians or simply being in charge, because they're not as medical directors in home care. And then some of the ethics issues that come up. Let's go on to the next slide and look at, and if we can move over if possible, or I'm not sure kind of the way this is lined up, but I'll just read some of this case so you can see it. Jack Henderson's a 55-year-old family physician who became certified in geriatrics a number of years earlier. His practice is, as he ages, practice is getting older, and he practices in nursing homes. As his patients have aged, he has more and more elderly patients, and he occasionally makes house calls to long-standing patients. He, as most outpatient physicians, has given up inpatient rounds, and at this point in his career, he's asked to serve as a home health medical director for a local branch of a national skilled home care agency. And so that kind of sets up kind of the viewer, the participant in this, trying to say, what would a person be like? And then if we go on the next slide, the question that would follow it is a series of questions as to, so why should Jack accept this? And one of the reasons is that it could be a source of referrals to his practice. His agency patients who don't have a doctor might get referred to him. That he can make an hourly income comparable to other things he does. That he can have impact on hundreds of patients per year without significant paperwork or on-call responsibilities. That he can learn how to better use home care, and finally that he can have a reason to join the American Academy of Home Care Physicians and participate in our activities. And the way this is set up, the participant in this training has to click all 5 choices. And if as he clicks on them, he gets a pop-up that tells him why that was a good answer. And if he doesn't click all 5 and tries to go on to the next slide, he's warned to kind of think about it again, and there are additional answers that may be correct. So in this kind of pattern, we reinforce kind of for the person at the beginning of this training kind of why they're doing this in the first place. So let's go on to the next slide. This is a slide about the organizational culture in home care, and this is from some literature on, in general, organizational cultures. And physicians come from models of competence. If you're in academics, the more degrees or the more papers you publish, the more important you are. And there's a hierarchy of chairmen of departments and division heads and then staff physicians. And hierarchies in terms of assistants and associate professors. The military has a command and control. Churches and some other types of organizations have a leader that, based on their personality, the direction of the organization goes. The challenge is that physicians coming to their practice thinking their practice every day, they can say, well, you know, I'm going to be in control. I'm going to tell my patients what to do. Or I've been here around, I have seniority, or I'm smarter than my colleagues or smarter than nurses, so I'm in charge. In home care, it's a much more collaborative model, and the teams are more important. And part of this training and part of recruitment and retention of medical directors is to help them understand that they have to be more collaborative than they might have historically or thought they need to be. And connected to that, that in home care, the physician is really the most knowledgeable about most things in home care, is rarely in charge, and is rarely accountable for the process or outcomes, which is very different than other aspects of a physician's work. And so it requires thinking about that difference in order to fit in. Next slide. This is an example of a clinical case study. After starting his role, Jack is presented with a patient who has painful daily dressings and a complicated home situation, and the patient's refusing further care. And the question is, what should the medical director do to respond to the question, what should we do? And a variety of choices, and the correct answer is the one at the bottom. Rather than taking over the care or saying we don't want the patient anymore in our agency, the medical director should recommend consultation with a wound ostomy nurse or a referral to a wound clinic to see if there's a better way to manage this wound that might not be so painful or may not be daily, because both of those are problems for home care nurses. So this is an example of an important role for a medical director where the staff nurse of the agency may feel stuck and go to their supervisor and say, I think we need to discharge this patient. But that's rarely to the benefit of the agency overall, because it can both lead to a bad outcome on OASIS scores as well as upset the referral source and lose that referral source to other agencies. Next slide. Another example of an embedded question, in addition to the content slides, is an expectation that the physician knows something about the agency that they're working with. And so after explaining what a low utilization episode is, where the agency is paid just about $100 per visit for up to the first 4 visits, the question is, how often does this happen for the agency that is being trained in this program? And for each of the answers, there's a pop-up that gives information about what they should do. And the vast majority of people who would be participating in this training would probably answer E. I don't know what the LUPA rate is in this agency. And the pop-up that comes if you choose that is, well, go ask. If it's at the high end, over 20%, the agency has too many, and they're either accepting too many patients who aren't appropriate for home care or having too many bad outcomes very quickly and sending people to nursing homes or having them die too quickly. If it's way too low, then they may be too restrictive, or they may be keeping patients open even without necessary services, and those would all be warning signs because the typical rates are kind of in the maybe 10% rate nationally. Next slide. So getting to what this training, kind of how it works and what does it cost. Some of the common questions that have been asked about the training is how much does it cost? And this is the cheapest, the least expensive, high quality online training that isn't sponsored by a drug company that I've encountered. And so for Alliance members, for Academy of Home Care Physician members, we're only charging $20, which is really just nominal to demonstrate an interest in it. The Alliance members are some of the larger national organizations. I would encourage you to encourage your member organizations to not only have their medical directors trained, but for them to join the Academy of Home Care Physicians. Our newsletter and our programs and our advocacy are all important to home care agencies. And so the easiest way is to do that, to have those medical directors join the Academy and participate for the $20. We're promoting this through the Alliance and their members and agency administrators, through the Academy and our members directly, and then through webinars like this, through state associations where you have your dozens or hundreds of members in your state. And if you can promote this across your state, we'd very much appreciate it, and I think that could help you help your agencies realize how they can do a better job. The other way that medical directors can be encouraged, besides finding out about it, is for the agencies to compensate the physician medical directors for their time and participation. And because it's a known amount of time, 4 hours, it's kind of manageable within the contract, which are typically hourly rates. And that's the easiest way to be in compliance with the Stark and anti-kickback rules to avoid getting in trouble. So ideally, the medical directors would do this within the scope of their contract, whether it's on site when they're there or at home, but they obviously can demonstrate that they spent the time. And it's worthwhile. If an agency wants more and better use of that medical director who's only spending an hour a month maybe coming in, they'll be able to actually find useful purposes and value in that medical director for this investment. And I think we have one more slide. So to register, you can go to the Academy Home Care Physician website, and on the left panel there's a link to Home Care Medical Direction. You can look on the website for more information or contact our executive director. So with that, I wanted to, I find these webinars, if we can keep them to half an hour plus questions, that works well for everybody. And are we able to open this up for questions? Audrey or Connie?
Yeah, just a second. If there are questions, please feel free to type them in, and we are most anxious to hear from you. If you do have questions, do go to our website, and if you have questions that have not been answered in this webinar, you're welcome to write me as well at edrao@ahcp.org. No typed questions? Okay, that's half an hour. Thank you very much, Dr. Ratner.
Okay, thank you.
Thank you. Bye-bye.